Okay, so what have you guys covered in ER and CMS so far? Not much? What did you say? One or two lectures? Okay. So I'm going to talk about kind of new drugs. So again, we could have whole courses on using drugs in emergency room setting. We talked a lot about a lot of these drugs already. So for instance, if a patient comes in with nausea, vomiting, what are you going to give them? Zofran, right? Zofran is good for most patients, right? So I'm not going to go into that sort of stuff. Like we already know a lot about treatment of those sort of things. We already know about those drugs. Again, you're going to use them very similarly in the ER. I'm going to focus on the some new settings, some new drugs we haven't talked about before because this is the good spot to talk about them. So the first thing we'll talk about, and you guys haven't had any ACLS stuff yet, right? Correct. So we'll go over that a little bit. We'll talk about some of the drugs we're going to use for that. So that way by the time you get to talking about ACLS, you'll be much kind of better prepared for that. You'll know more about the drugs, specifically what we're going to use, when to use them, etc. So first thing we're going to talk about is rapid sequence intubation. What is rapid sequence intubation? It's where you need to intubate your patient rapidly, usually in a sequential process. Yeah, would have been fine. Right. So again, would you want to do this to an awake patient and feel everything? Not typically, right? They're usually going to fight you in a lot of cases. So we're going to look at the drugs. They're going to be important for getting this process to be as safe and as smooth as possible. And again, when are you going to be doing this sort of thing? When do you intubate patients? They can't breathe on their own. Usually, if their mental status is so depressed, they're not able to really breathe on their own. If they're not really protecting their airway very well. Yeah, prior to surgery, certainly. Yeah, so again, this is going to have some bleed over with the surgical stuff we'll talk about later. We'll talk about general anesthesia when we get to the surgery section in the next part of the class. But we'll talk about here specifically in the ER setting, we need to kind of a rapid intubation. When you're going for surgery, it's kind of a nice controlled setting. Usually the patient's not, they're probably sick, but they're not like so sick as, versus like a trauma is coming in, level 1 trauma, where they're having, pretty serious injuries and going on, they're hypotensive, etc. So let's look at the stuff we're going to use for. Again, this needs to be a very rapid process, usually within the course of a few minutes. Hopefully we're going to have that patient intubated. And so you need to make sure you have good preparation for this. You want to make sure you've kind of assessed the patient, trying to get as best a history as you can regarding the circumstances for why they need to be intubated, their medical history. We'll talk about key points there because this will influence what drugs you select for those patients, okay? If you use the wrong drugs, you could potentially kill somebody by doing this, okay? We'll talk about the sedation aspect of it. So you want to knock this patient out, because you do not want them to be conscious during this process. And then we will do paralysis. Okay, what is the point of paralyzing the patient? Yes, they won't have any gag reflex, obviously, because they don't really have any kind of muscular control. What's the other thing? It will loosen up all this muscles here, so that way, because when you're putting that laryngoscope, you need to kind of pull up their airway, essentially, so you can get that intratracheal tube through, right? I'm probably speaking about this kind of ineloquently, however, because I'm usually over on the side with the drugs, getting those ready versus actually doing the intubation. I did it on a mannequin one time. That was fun. However, my dad, he's a CRNA, and he's been doing it since male nurses have not ever been a thing. So he's back in the 70s, he started doing this stuff. So he's probably intubated more people than probably in this, I don't know, thousands of people, I would guess. He's been doing it for 30 some odd years. But anywho, so he's done a lot of intubations. He's quite familiar with that. So get a few pieces of information from him here and there. However, though, the main thing here is we want to safely, quickly intubate these patients. That way we can start to breathe for them. You kind of deal with any other issues that are going on. So anyway, the history is super, super important before you go pushing meds for these patients. Because again, usually in the ER, is this a very calm, kind of cool, collected sort of process? No, it's usually going to be pretty hectic in a lot of cases. And so certainly the more you get kind of practiced with it, the better off you're going to be, the better prepared you can become. But if it's your first time seeing it, it can be very, very kind of hectic, very kind of harrowing. Big things to note, though, from the history is look for allergies first. Obviously, you're going to be asking about allergies. Now, is the patient going to be in a situation where you can ask them directly? Not generally, right? Not always. So this is where if you can talk to your EMS buddies, before they leave the ER, try to get some history from them. If you can talk to family members who might be there, this is where you can get most of your information. You want to ask about history of neuromuscular disease, things like ALS, things like muscular dystrophy, things like that, because that will influence selection. One of the drugs we'll talk about in a second here. Again, a lot of small children, especially maybe undiagnosed, because again they are just young enough where the disease hasn't really manifested itself yet. Look at for things like renal compromise. Any renal history is going to be important here. Talk about why a little bit later. And then usually you have a history looking for malignant hyperthermia. Anyone heard of that term before? Probably mentioned. When do you get that? The succinylcholine will be one drug we'll talk about here that will do that. Any other drugs? Yeah, so inhaled general anesthetics, we'll talk about it being causing that as well. This is something we'll talk about more in the surgery section, but it is something where potentially life-threatening that can occur. So you want to ask, do you have any history of bad reactions to anesthesia? You know, does your family have any history of bad reactions to anesthesia? Because there's a genetic link with this, right? So if you have primary family members who are, have had a history of malignant hyperthermia, even if they don't know that's what it was, if they have a bad reaction, that's what you kind of want to ask for. The patient's more likely to have it as well. We'll talk about why a little bit later. Also looking for things like asthma, that'll become important for drug selection as well, and then previous intubations or anesthesia. So just see what they've gotten before, see what they've had good reactions to, bad reactions to. Some of these patients have been intubated several times, and so it's good to kind of have an idea of kind of how it went previously. So what kind of happens with a patient when you're trying to intubate them? Several physiologic responses occur due to this. So you can see big changes in heart rate. So some patients may become more tachycardic. In a lot of cases, you'll find this vagal reflex will initiate and they'll become bradycardic. That'll be important because some of the drugs we'll see actually can cause bradycardia as well. Typically, you see a spike in intracranial pressure. Who might that be bad for? Patients who already have increased intracranial pressure, think head trauma, think they have cerebral swelling, cerebral edema, that could be bad, right? So again, it's important to look to see like, well, who might be at risk for having intracranial pressure issues. Usually head trauma patients are going to be one of the kind of the big ones you think about. You're usually going to see increases in blood pressure, and you can also initiate this kind of bronchospasm, right? So you can have the increased airway resistance that can occur secondary to this. So these are all going to be things we're going to look at as trying to pre-treat, and things we just know are going to happen with every patient who's going to get intubated. So first drug we're going to use here is lidocaine. Where did we use lidocaine previously? It's a local anesthetic. What else do we use it for? Antiarrhythmic, right? Remember how it worked? Block sodium channels, right? So again, you prevent action potential propagation along a nerve. Does it in the heart. We'll do it to nerves. Acts as a local anesthetic. So what this is actually going to do is it actually can help to kind of numb up the throat and will kind of help to prevent that gag reflex essentially, right? That's kind of the big thing that will cause that increase in intracranial pressure, that spike. You imagine you can think, activate your gag reflex like you throw up, but you're going to kind of bear down. Intracranial pressure is going to go up as a result of that. So what I can actually do is numb up that kind of whole area to kind of prevent that. And so you see blunting of that rise in ICP. That's not the insane clown posse, though. Don't think about that. Intracerebral pressure, right? So what we're going to do is if you have a patient who has a traumatic brain injury, if you're worried about having increased intracranial pressure, this is when you want to give lidocaine. Again, I'm not going to ask you on the dose specifically, but this is one of the drugs we'll give as pre-treatment, right? Before we give the sedation to the paralytic, we're going to be giving pre-treatment meds. This is one you may do, right? So for instance, if I ask a question on a test, say you have a patient coming in, for a trauma, a car accident, they bang their head on the steering wheel pretty hard, you're worried about intracranial pressure increases, what drug would you give as pre-treatment? Lidocaine is going to be the go-to for that one, right? So again, usually can be used as an antidysrhythmic. However, the doses are going to be a little bit different here. You may see it used more frequently as a local anesthetic for things like, prior to getting an IV or laceration repair, things like that. But that's the big thing is doing here is trying to blunt that cough and gag reflex during the actual, when you're trying to actually do the intubation itself. The next drug you would use is going to be atropine. So what does atropine do? So it's going to be acting as an anti-muscarinic, right? Anti-muscarinic, right? So this is going to be blocking muscarinic receptors, which normally get activated by what? Acetylcholine, right? So again, this is what you would use. Sometimes you'll see it used ocularly for trying to dilate the pupils so you can get a good exam. We would use this very frequently. We'll talk about this in ACLS as well, and used for bradycardia specifically. So when you block acetylcholine on those muscarinic receptors on the heart, what is that going to do? It's going to increase heart rate, right? Because again, that vagal response, when you have vagal activation of those nerves, it's going to slow down heart rate, right? So again, think back to the anticholinergic mnemonic. You remember what those do? Remember, it's going to see tachycardia associated with that. So again, heart rate's going to go up. So again, this helps to prevent that bradycardia that can occur with patients who are going to be at risk for becoming bradycardic during intubation here. So ways or patients you might think become bradycardic, obviously they're already bradycardic at baseline. This would be one case where you want to go ahead and give atropine beforehand to try to speed that up a bit. But certainly this will block that vagal stimulation that occurs during visualization with a laryngoscope. Succinylcholine is also going to be another drug that can actually induce bradycardia. So we'll talk about that in the succ section a little bit later on. But when I say succs, I'm referring to succinylcholine. But sometimes we'll end up giving atropine as a pre-treatment for that. So again, if they're already bradycardic coming in, we would give atropine as pre-treatment. Okay. So those are the main two pre-treatment drugs, right? And again, this has to be a very rapid sort of assessment, because if again EMS is bringing in the patient, they're bagging them, they say, hey, you know, got this history, blah blah blah. You need to be able to really kind of quickly assess like what drugs I need to give this patient, right? And again, this is why it's good to have a multidisciplinary team that's there, because again, the doctor's gonna be making a decision. Okay, this is what I want to give, and I'm like, wait a second, did you think about this? And they say, okay, let's go ahead and give that drug additionally, right? So these are all kind of things that, you know, having multiple heads in the room, you know, if 2 heads are better than one, having like, you know, 6 or 10 heads in the room can sometimes be better. Sometimes it can be a little bit more chaotic, but generally good to have, you know, that good interdisciplinary team to kind of think about things from kind of all angles, essentially. So moving on, next we'll have our induction agents, and these are going to be the sedative drugs that we're going to give these patients to try to make them basically unconscious. And so do you think we're going to give drugs that are going to be lasting a really long time in these cases? Typically, no. Typically, you want to go ahead and give them something that's going to be pretty short acting, because if you are not able to intubate them, you typically want them to try to get their respiratory drive back as best you can, right? Because again, not every intubation is going to go successfully, especially in these kind of emergent sort of situations. So you want short acting medications typically. And again, that is also going to be useful, because imagine if you have someone like say like a stroke patient or a patient with any kind of, you know, say neurologic injury, when they're coming in, you want that usually to wear off, because then you can do your neuro exam, right? If they're still paralyzed, if they're still super sedate, you may not be able to do a good exam on them and kind of get a good assessment for what's happening with the patient. So that's another reason why we like short acting kind of sedatives here. A couple of drugs we'll use. First one's going to be called Etomidate. Amidate, it's the usual brand name. And so this is going to be a sedative hypnotic kind of categorization. What other drugs kind of fit in that category, as we talked about yesterday? So I think of benzodiazepines, right? So again, think about these being a very strong sedative agent. The nice thing here is very rapid onset, very rapid offset. So again, within 20-30 minutes or so, it should start to wear off, right? Other nice thing about this is minimal hemodynamic effects. So it really doesn't affect blood pressure, really shouldn't affect heart rate, and really doesn't have any strong negative effects on respiratory drive, right? One of the big things you're going to see with most of these drugs for sedation is they will knock down your respiratory drive, and the patient most likely become apneic. Okay, this is nice because it doesn't really have that big of a hit of respiratory drive. So if the intubation does not go well, they still may be able to retain that a little bit. So again, not really similar to any other sedative agent out there, but we do know it helps to kind of enhance GABA. Again, working on kind of a different steroid site on the GABA receptors than you would see with any of the other drugs. Just know it's a good, strong sedative agent, and this is one of the biggest use cases for it is going to be during intubation, either in the OR or in the ER. So you mentioned enhanced GABA. You see more GABA A activity, which we mentioned that's kind of where our benzodiazepines are working at as well, is trying to make GABA A work better. And then so depending on the dose, and again all things everything can be a poison in the right dose. Similarly, this can cause at low doses light sleep all the way up to a very deep coma, which usually we're shooting for the deep coma side of things. And again, other things you're going to note here. As you can see that, kind of similar to things like barbiturates, which what's a good example of barbiturate? So I think phenobarbital, pentobarbital is another big one you may see being used for intubations as well. But again, you get a very similar sort of kind of CNS depression associated with that. So again, very good sedative agent, usually in the setting for RSI. So this is the main place we're going to be using this. And again, you always want to give your sedative before your paralytic, right? Because when we talk about paralytics, does that do anything to your perception, your level of consciousness? You're going to find no, it does not. So again, you always want to make sure patients sedated prior to getting paralytic. You guys ever heard of those like cases like people who go to surgery, they have like that sleep paralysis sort of thing going on where they're still conscious, they still know what's going on, but they're paralyzed? Sounds terrifying, right? So you don't want to do that to your patients. The nice thing with Etomidate, there's no real good contraindications besides that they have an allergy, which I've never seen anyone actually have an allergy here. So a very good drug for most patients. However, one of the things you want to be very careful from, and again, very rapid onset, so it's good here, very rapid offset, which again I mentioned is beneficial for doing things like neuro exams and whatnot. The main side with this drug, let's see here, don't put it on this slide yet. And again, you don't need to know the dosing. I'm just kind of putting this here for reference, so you can kind of look back at that to kind of see kind of how we would use this normally. But again, very, very quick offset for most patients. Note here is going to be, so as far as drug interactions go, a lot of synergistic effects with other sedative agents. So they've already gotten things like benzodiazepines. So say like you had a seizure patient you wanted to intubate, and they already had say benzos being given for the seizure. This is going to be synergistic with that. It's a thing to know. However, it does not interact with any neuromuscular blockers, which are going to be our paralytic agents we'll talk about a little bit later. The big side effects you want to note here is that you can see pain at the injection site, but again, hopefully you're going to be making your patient unconscious, so you shouldn't really be too cognizant of that. You can see this trismus and muscle twitching that can happen here. When I say trismus, what is that? Yeah, basically kind of like lockjaw. And do you think that's a good thing to happen when you're trying to intubate a patient? Negative, right? So it's a very rare side effect. It does not happen too frequently. However, it is a concern. However, this will be mitigated by giving a paralytic. So it is one thing to note. Some docs are a little bit more gun shy about using Etomidate because of this, usually if they've had a bad experience. But just know that is one thing that can occur. You may see some like myoclonic jerks, things like that. However, that's just related back to the actual drug. This will be important too because we'll talk about one of our paralytic agents that actually causes kind of the same thing. So you want to be kind of just watchful for that. Okay, so this is a big thing I wanted to note here, especially with patients who are going to go to the ICU, patients who are going to be potentially, say, cortisol deficient. This can actually end up decreasing plasma cortisol concentration. So you get this kind of transient sort of adrenal suppression. That can be important because what does cortisol do for, like, say, our blood pressure? Helps to regulate it, right? So if you don't have enough cortisol, you're not going to have enough mineralocorticoid effects. You're going to find blood volume typically decreases. Be more leaky capillaries, blood pressure is going to go down, right? This is one of those cases where I'll have patients who will go to the ICU and they get put on a bunch of pressors and like, wait a second, they got Etomidate, you know, in the ER. Perhaps we can supplement them with some hydrocortisone. Certainly give them hydrocortisone, all of a sudden the pressure requirements really go down. We'll talk about vasopressors a little bit later. So just be aware of that, especially with septic patients, because typically when they're kind of that chronically stressed, they develop a tendency to have a kind of an adrenal suppression as well. So again, just think about that. Make sure that when whoever the receiving team is, they know that they received Etomidate, and that could be something they see as that cortisol deficiency. Okay, some other drugs we can use for sedatives. We have Midazolam and Lorazepam. These are obviously what type of drugs? Right, these are going to be our benzos, and so these are going to be good at providing good sedation. They are amnestic agents, right? So they're not going to have any kind of good memory of what happened during the intubation. And also going to be good for anticonvulsant properties, right? Because we mentioned so things like status epilepticus or seizures in general. What's our go-to drug? Benzos, right? So again, these are going to be good drugs to use for that. One thing to note here, they don't provide any sort of analgesia. So you may want to use this in combination with something else, especially if they're like, say a trauma and they have a lot of painful injuries, things like that. You're going to find that Versed typically has a little bit faster onset. And again, a lot of this has to do with how lipophilic the drug is. Usually lorazepam is more water soluble, which we remember because we said what are the good benzos for old people. A lot. Remember, in lorazepam is that one there. So it gets more water soluble, doesn't like to cross the blood-brain barrier as quickly. However, it is still one of our go-to seizure drugs, mainly because it sticks around the CNS for longer. So most of the time, for patients getting intubated, you'll see more Versed being used there, more Midazolam being used more frequently. So I am, for one, am not a big fan of using benzodiazepines for sedation during an RSI, mainly due to the fact that it kind of lasts too long. It just really kind of sticks around for a while, and I've kind of seen kind of variable effects where patients don't get sedate enough for the procedure itself. Like if you get something like Etomidate, like you give them a good dose of that, they're knocked out. They're completely unconscious. Versus this, sometimes you have to give repeated doses to really get them down. But I have some docs who prefer to use this over anything else. It's just kind of what their preference is for them. So for instance, you can see here that typically you'll give sometimes even bigger doses than what you would normally use for like, say, like a seizure to try and really make sure you're inducing that sedation for these patients. It works within a minute or two, not as quick as something like Etomidate, but still pretty quick. And you may see, effects for 15-20 minutes, but I usually see much even longer than that, up to like an hour, hour and a half, where they're really still pretty sedate from the benzo. The only thing to note with these is patients they're going to have longer half-lives. Usually they're obese because, again, I mentioned like Versed being more lipophilic, so it's going to partition that tissue and stick around for longer. Hepatic renal insufficiency. Just know they're going to be holding on to that drug for a longer period of time, so they're going to be sedated for a longer period. Next up we have ketamine, or special case, one of my favorite drugs. You remember how this one works? Actually a derivative of PCP or phencyclidine. Anyone know the street name for PCP? There's a lot, but what's the most common one? Angel dust is the most common one. If you hear angel dust, you normally think PCP. But we have ketamine. It's actually a derivative of that. And so I don't see a lot of people using PCP nowadays. Usually a lot more amphetamines, but it's another side tangent. But this is, sometimes called Special K. It's a very good anesthetic sort of agent. Kind of the nice thing about this one is pretty short acting. The other thing that's good about it, it actually causes catecholamine release. I mean, it's going to be releasing more norepinephrine. So where like something like, like Etomidate is pretty neutral on hemodynamic status. You normally don't see a lot of changes in blood pressure, heart rate. Versed, other benzos, you may see some drops in blood pressure. Not going to be too significant, but you may see that. This is really nice because it causes that catecholamine release. It's good for patients who are bradycardic or hypotensive. So you have a septic patient who's hypotensive, you can give this to them, kind of bump up their blood pressure. Anyone who's really hypertensive, you can give that. Very nice. Yet, other thing here is it's a bronchodilator. Because again, we know that these catecholamines are going to be activating those beta-2 receptors in the lungs, and it's going to cause bronchodilation. So who might that be good for? Yeah, so the thing about status asthmaticus, it's not too frequently have to intubate an asthmatic patient, but it does occur. That might be a really good drug for them because that would help to kind of loosen up the airway a little bit. I've seen some asthmatic patients get intubated being placed on ketamine drips because of that bronchodilatory effect. The other nice thing is it will leave the respiratory drive intact, right? Versed, you're going to lose your respiratory drive. Etomidate, you have a chance of losing your respiratory drive. This one remains intact in most cases. So this is really good. And the place I've seen this used more frequently for adult patients is going to be cases, something like angioedema, right? So say someone's like taking, what's a good drug that can cause angioedema? Yeah, it's I think ACE inhibitor. So I think an ACE inhibitor comes in. What does someone look like when they have angioedema? Everything's blown up, right? How easy do you think it is to visualize the airway with that kind of patient? Not at all, right? So again, it's going to be very, very difficult. So oftentimes what they'll end up doing is they'll do a fiber optic scope, right? So they'll actually go down the nose, and then you can actually pass an ET tube via that route if needed. So because of that, you need the patient to be somewhat awake. Usually they're kind of sitting up when this process is occurring. And so we will actually use ketamine because it helps to maintain the respiratory drive. Because the only thing is, like, if they stop breathing while they're that blocked off and you can't get that tube down the nose, what's the only other option? Yeah, I do cricothyrotomy, right? So again, you never want to have to do that if you can avoid it, but again, that would be the other option. So ketamine is really good for that. So I remember this one guy who's taking his lisinopril and just came in, entire face just completely blown up, and he's doing the scope and gave him the ketamine. Anyone know what people are like when they're on ketamine? It's a kind of dissociative sort of effect. And so this guy was still awake, he's still conscious and trying to talk to us, but man, he was having a religious experience. Like, it was just, he was talking to God, he's talking to Jesus and everyone else in the room, and just saying, like, I swear I'll never take that ACE inhibitor again. I'm so sorry, just let me live through this. And I was like, oh, that's kind of sweet. Fortunately we were able to get him intubated, but very interesting, ketamine, hell of a drug. Anywho. But those are the nice cases, right? So you think about your patient, think about the use cases where one drug might be better than another. If I wanted them to keep their respiratory drive, ketamine is great for that. However, you can see some spikes in ICP because, again, we're increasing releases these catecholamines. You can see their ICP jump up. So if I had a head trauma patient, guess what? Ketamine is probably not a great option for them in those cases. Or if they're already really severely hypertensive, this may not be a good drug for them in those cases. The other things you can see with ketamine, you can see it's a sialagogue. Anyone know what that means? Increases saliva production, right? So this is something that can be problematic because, again, when you're trying to visualize the airway, if you got a bunch of saliva kind of blocking your view, it's not going to be any good, right? So again, not always going to happen. This can actually be blocked by atropine because, remember, atropine being an antimuscarinic does what to secretions? Dries them up, right? So you can actually give atropine to dry them up in case that's occurring there. So I mentioned intracranial pressure. This may be controversial, but most people will avoid it if they have any kind of history of head injury or cerebral edema, anything like that. And some patients will experience a dysphoric reaction. So again, it's when you go down the K-hole and you have a bad trip with this. You tend to see this more like adult patients where they're kind of coming out of the ketamine and they get very dysphoric, they get very kind of agitated. It can be a little problematic for them. Usually we have to give them some additional benzodiazepines to kind of calm them down a little bit. But hopefully these patients are intubated. Most of the time they're going to the ICU. Most of the time they're going to be on sedation for a long period of time anyway to try to make sure they're not going to. Because again, once you get intubated, if the sedatives wore off, like, how comfortable is it to have that intratracheal tube down your throat? Not very, right? So again, you need to sedate the patient to make sure they're not going to be, fighting the ventilator. Make sure they're going to be synchronous with that. So most of the time they end up on kind of long-term sedation afterwards anyway. But one thing to know, the other big thing is going to be vomiting, which, again, if you're trying to intubate somebody and they vomit, is that good? No, right? You don't want them to aspirate, so that would be a bad thing there. And again, just think about what's their blood pressure already, what's their heart rate. Do you want to make that worse? If they're bradycardic, hypotensive, that may be a really good option for them. Just kind of assess a patient and just know based on the drug what's going to happen with that. All right, so let's continue with our talk of sedation agents. So the next one up is propofol. Anyone know what notoriety propofol has?
Michael Jackson.
Yeah, there we go. Mike Shimon, as he would say. Shimon. Anyway, so propofol, right? So propofol, yeah, has a little bit of notoriety with Michael Jackson. Interestingly enough, and this is not a joke, the Jacksonville Zoo actually has one of Michael Jackson's elephants. And so we'd take field trips there as part of a tox rotation, and we would go like with the herpetologist, and we'd actually go through and see all the snakes and stuff. We got to go by the elephant thing. And I would ask students, I was like, oh, do you know how you can tell which one is Michael Jackson's elephant? And they say, oh, I have no idea. I was like, it's the one with one silver glove walking backwards. It didn't actually do that, but anyway, so propofol, yes. So propofol is a very good drug, sometimes called the milk of amnesia, because what do you kind of notice about the look of it? Looks like milk, right? So again, it's not super soluble in water, so we have to put it in this lipid emulsion in order to get it into solution. So that's why it has that kind of milky white look to it. Again, very good from a sedation standpoint, very kind of short acting, does not last too long. And so the only thing to note with this one is that, one, it will cause pretty significant hypotension, which could lead to seen as hyperperfusion. So there's one concern there. And then also you have to ask about egg and soy allergies, because that is actually not the drug itself, but the actual lipid base that we're putting it in has egg and soy proteins in it. So you need to make sure they don't have an allergy to that, otherwise it could have a cross-reactivity. And I can't tell you how many times, you know, I'd go into the ICU and I would see patients who are on dopamine, they're on epinephrine, they're on norepinephrine drips trying to fix their blood pressure, and they're also on propofol for sedation. And I was like, you guys know propofol causes hypotension, right? And they're like, really? And I was like, yeah, so try switching out something else. So they switch over to like a Versed drip or something. All of a sudden, patient's blood pressure come right back up. Their vasopressor requirement would go down. So think about these things when you're combining drugs, you know, especially with these really sick, potentially septic patients. The other thing with this, we will use it very frequently for procedural sedation. So, you know, if you think about like, you know, kids with like, say, like fracture reductions and things like that, we use a lot of ketamine. Ketamine is nice for short procedural sedations where you don't want to intubate, you don't need to do anything like that, because again, it leaves the respiratory drive intact. However, enough adult patients will have those dysphoric reactions, so we don't like to use it for them quite as frequently. So if you had someone who maybe had like a dislocated shoulder you needed to reduce or anything like that, propofol is a really good drug for that. So you'll see this being used quite frequently for procedural short sedations needed for those kind of procedures in adult patients. Anyway, there's a dosing there. But again, those are the biggest things. The hypotension, you can see with that, and the egg and soy allergy to note with that one. Okay, so those are the main sedative agents you would see being used for an intubation. Propofol, actually another nice thing about that one is it has some very good anti-seizure properties. So again, it's good if you had a patient who had, say, status epilepticus, you can actually utilize that, and that helps to really kind of knock down those seizures pretty well additionally. Again, ketamine really wouldn't have any good anti-seizure properties, so maybe one thing that kind of leads you to use propofol versus ketamine versus anything else. Okay, up next we have our paralytics. So again, what do you think paralytics are going to do? Going to paralyze our patient. Absolutely. How do they do that, you think? They block something. Some of them will block something. Anyone know what that something is? Not block sodium. Good thought, though. What causes our skeletal muscle to contract? What does that mean? Well, calcium is important there, but what's that kind of what's the neuron releasing onto that neuromuscular end plate? Acetylcholine, right? So you're going to see some of these are going to be all these paralytics are going to be affecting acetylcholine, right? And so again, those are going to be what type of receptors? They're nicotinic receptors, right? So again, these are not going to be muscarinic receptors we're affecting. It's going to be nicotinic receptors, right? Nicotinic receptors are good for neuromuscular end plate, the neuromuscular junction. They're going to be good for interneuron communication. Muscarinic is going to be good for that parasympathetic nervous system side of things, right? And so keep those straight. I know I taught you that, so go back and review those physiology slides. Anywho, so looking at neuromuscular blocker, so again, they're going to be typically blocking that transmission from the nerves onto that neuromuscular end plate there. And again, you're going to find they typically have no direct effect on other types of muscle. This is really only going to be for voluntary skeletal muscle. It does not affect the heart. Does not affect the digestive system, anything else like that, right? Really only going to affect the skeletal muscle there. This has no effect on level of consciousness or pain perception. So again, if you had someone who's undergoing surgery and they're only paralyzed with nothing else on board, they're going to feel everything. They just won't be able to respond to you at all, right? So again, they're going to appear like they're comatose, but they will still be experiencing everything. This also have no direct effect on seizure activity. So it's one of those things where if you have a patient who is in status epilepticus that needed to be intubated and you gave them a paralytic, they could still be seizing, right? They just may not be able to have those muscular contractions due to the fact that they're paralyzed. How could you tell if they're still seizing or not? Yeah, so sometimes we do like a bedside EEG or something to try to see if they're still seizing. So we've had to do that on occasion. There's going to be two main types we're going to see with this. I don't know why I put animation on this slide. The two main varieties we're going to see here, one of which are going to be our depolarizing neuromuscular blockers. Let's say depolarize, what do you think that means? It's actually going to cause an action potential. It's actually going to cause a contraction of that muscle initially. And what we're going to find is that it will cause those actual receptors, those nicotinic receptors, actually tire out over time. So we'll talk about how that works in a little bit here. But here, depolarizing neuromuscular blockers, the one you want to think about is succinylcholine. Okay, succinylcholine depolarizing neuromuscular blocker. The other varieties we have are going to be non-depolarizing neuromuscular blockers, and these are mainly just going to sit on that nicotinic receptor and not cause anything to occur. So they're blocking acetylcholine from actually activating those receptors. Main ones you're going to see here are going to be things like pancuronium. We're going to have rocuronium, which rocuronium is going to be a very common one we're going to use for intubations, and we're going to see vecuronium is going to be the other big one. Okay, so again, these would be non-depolarizing neuromuscular blockers, and that'll be more apparent when we talk about how these drugs are working in just a second here. So again, they're classified on their specific actions on that neuromuscular end plate, not specifically based on their mechanism, but really just how they're interacting with that end plate there. So if you imagine, we have our motor neurons, right? So again, we're going to be having these axons sending down their action potential, right? And they're going to be eventually releasing acetylcholine onto these nicotinic receptors, okay? This is the main axis, or main means of transmission for those onto the skeletal muscle. So with acetylcholine, typically what we're going to see is that, acetylcholine is a very short half-life typically. You're going to find it gets broken down very quickly into acetyl-CoA and choline, which can then eventually be recycled. And there'll be ways we can affect this, right? So we've already talked about things like acetylcholinesterase inhibitors before. Where do we use those at? You can use them for myasthenia gravis. We mentioned that yesterday. Absolutely, that's correct. What else do we use it for? There are a certain neuro condition. You guys probably forgot about it already because you might have Alzheimer's, right? So again, we use acetylcholinesterase inhibitors. We use ones that are trying to be more specific for those CNS varieties of it. But by increasing acetylcholine levels, you increase those kind of memory-based neurons there. We're going to see those are going to have a role here as well. We might talk about that more in the surgery section a little bit later on. But anyway, acetylcholine. Normally what you're going to find, imagine this is the neuromuscular junction here, you're going to find that right now we only have one depolarizing neuromuscular blocker, that's going to be succinylcholine, otherwise known as Anectine, would be a brand name you might hear. And the nice thing about this is going to provide very rapid onset of action. You're going to be able to cause paralysis very, very quickly, and it's relatively short acting for the most part, which are good things when we're thinking rapid sequence intubation, right? Especially if things go wrong, if you cannot intubate that patient, do you want them to be paralyzed for a long period of time? No, you want them to be able to get that muscle control back. We call this a depolarizing neuromuscular blocker because you're going to find that initially what this is going to do is it will actually activate these nicotinic receptors. So it will initially cause an action potential to occur. It will cause an initial fasciculation, right? So it will cause actual muscle contractions to occur. And then it's basically going to wear out that receptor. It's going to basically tire it out by keeping it activated and open for so long that it's basically going to become desensitized, okay? So this is why we see these fasciculations that occur here. This is what's called a depolarizing neuromuscular blocker, okay? So, the main thing here to note is it also is going to be metabolized by similar plasma esterases as normal acetylcholine would be, because succinylcholine is actually basically, it looks like two acetylcholine molecules put together essentially. Now, there's some pharmacogenetic differences between people. Some people have very fast-acting plasma esterases. Some people may have a slow-acting, which can change how long this drug is going to work for. So there's no good way to test for that. It's just something to note that some people may have a more longer duration of effect from this drug than others. It's related back to their ability to metabolize it. As I mentioned, there's two different phases of this blocking here. The initial phase is going to be due to this kind of prolonged stimulation of that acetylcholine receptor. It's going to sit there on the receptor, keeping it activated, so it will cause an initial depolarization, and it'll just kind of stay on there, keeping it open. And so then eventually it's going to tire itself out. It's going to become desensitized, and that's where you get this eventual flaccid paralysis that occurs here, right? So it's going to start with initial contractions and then cause a paralysis to happen. So that's why if you give it, you'll see patients will actually have some contractions there, totally normal. That's what you would expect to see with succinylcholine, right? And then you should see the paralysis that will start afterwards, right? So basically what we're doing is keeping the cells within that refractory period, right? So we're keeping them where they can never kind of get back down to their baseline, where they can have another depolarization. We're keeping them in that absolute refractory period as long as we can, as long as the drug is being given, essentially. Okay. All right. So anyway, so again, eventually will become desensitized. It will take time for them to kind of reset themselves after the succinylcholine is gone. But again, this is a relatively quick process. So if I give you a single dose of the succinylcholine, by 10, 15 minutes, it's already starting to wear off. So this is a very short-acting drug, which we mentioned is good from an RSI standpoint. So again, you have to be very careful with paralytics. So what do you think would happen if you accidentally gave a paralytic to a patient who is not going to be intubated? They would stop breathing, right? Because their diaphragm is going to be affected by that. They would not be able to breathe, and they could die. So this is one of the things where you definitely do not want to screw around with this. Usually, whenever you find these drugs, you're going to have big signs that say, "Warning: paralytic will kill somebody. Do not use this stuff if you don't intend to use it." And it's really make sure that we keep it segregated from the other meds. Because again, if you were to give that one incorrectly, or say for instance, what can happen, I can see this happening very easily. Say for instance, we have someone coming in needing an intubation. I'm there as a pharmacist drawing up medications, and I hand both syringes over to the nurse. Let's say I didn't label them, and I just say, "Here's your Etomidate and your Succinylcholine." Nurse says, "Okay, which one do I give first?" And I was like, "I don't remember. I didn't label them." So they push the paralytic first. Not good, right? You need to get that sedative first. That's why, and again, I mentioned these RSI situations, are they typically calm, cool, and collected? No, it's very hectic. So you got to make sure this is why we practice so much. This is why I do simulations, to make sure that we are good at this. Make sure that everything's labeled appropriately. Make sure you know what you're handing over. That's why we do a lot of closed loop communication, where I say, "Okay, here's the succinylcholine I'm giving you, this dose, blah, blah, blah." And the nurse says, "Okay, yes, thank you. This is the succinylcholine, this dose." And that way we make sure that everyone's on the same kind of communication level. Make sure everyone's getting the right information there. Because again, you do not want to paralyze somebody that is not sedated. Anywho, so again, when you're going to be giving this, typically you're going to give it around 30 to 60 seconds after the sedative is given, right? So again, you're going to be giving your pretreatment drugs first. If you need to give Atropine, Lidocaine, you're going to give that. You're going to give your sedative drug, either Etomidate or propofol or Ketamine, about a minute afterwards. And again, you want to be timing this stuff, because again, your impulse when you're trying to intubate someone is to what? Go slow or go fast? You want to go fast as you can, right? And so what feels like, a minute and a half or 2 minutes is probably only like 20 seconds, right? So this time dilation effect, or time scrunching kind of effect occurs there, where things do feel like they're going by much quicker than they actually are. And so this is why it's good to have like timers and a lot of clocks and things like that, and that's why documentation is so important. But basically, give it a minute or so for the sedative to kick in. Then you're going to give your paralytic, in this case succinylcholine. You should see within 30 to 90 seconds or so, the patient should be paralyzed at that point. You'll see those fasciculations potentially, and then once that's done, then you're going to have a nice flaccid paralysis occurring there, and the patient will be very loose, and you'll be able to intubate effectively. And again, duration 5-10 minutes should start to wear off after that point. So we'll talk about what to do if you have a kind of a longer intubation going on, but in general, that should be all you need for most RSI cases. So, as I mentioned, binding those nicotinic receptors will cause an initial depolarization and then eventual desensitization, and basically being in that refractory period for a long period of time, right? Okay, so there's some contraindications here to know with succinylcholine. So, given to the wrong patient, you can absolutely kill somebody. Okay, so it's good to know when not to give it to them, and I'll talk about why this is in a second. These things are good to remember, and the time frame is going to be really important here as well. So for instance, we're going to find that acetylcholine receptors in certain injuries tend to become upregulated with time, okay? Talk about some of the side effects in a second here, but for instance, when you have a severe burn, 2 to 3 days afterwards, you're going to have this upregulation of acetylcholine receptors on the muscle. You're going to find they tend to be more sensitive to the effects of acetylcholine. It's going to happen with like massive crush injuries. It's going to happen with spinal cord injuries, after 3 days or so. And so you're going to find that you do not want to give succinylcholine after this period of time, because it's going to cause too much of a dramatic effect. We'll talk about what that is in a second here. But just know these contraindications. That narrowing glaucoma that can be worsened by succinylcholine. This is another one where malignant hyperthermia you want to be very careful with. You want to administer this drug if they have any history of that. And also they have pseudocholinesterase deficiency. Those would be those patients who have a deficiency of that enzyme. They may not be able to metabolize it quite so well, but most patients are not going to know that. And then any history of neuromuscular disease. So if they have ALS, they have muscular dystrophy, anything like that, you want to be careful with that, because again, they also will have those kind of upregulated acetylcholine receptors. And then the last thing would be hyperkalemia. Yes, ma'am.
How does the timing work on that? So like you can give the drug before 2 days?
Right. So if I have someone who comes in, Exactly. All right. So, and again, this is for a period of time, right? So again, eventually those receptors will start to downregulate over time. But yeah, so a lot of people will say, okay, well, I have a patient coming with a burn, can't give them succinylcholine. If the burn just happened, you're okay to give it, right? But it's one of those things where a lot of people just say, well, there's so many contraindications, I just don't want to use this drug ever. A lot of newer providers will probably have never used succinylcholine in their life, but for a lot of old school guys, like they still use it very frequently, and I've used this drug. Definitely more in adults than pediatrics, but a lot of people still utilize this drug and they'll still see it used quite frequently. Yeah, but the timing is going to be important there. If it's within 12 hours, 24 hours, you're still good to go ahead and give it. Just at a 2 or 3 day time period, you want to probably hold off on that, right? And again, it's going to go back to the hyperkalemia, because what you're going to see is when you have initial activation of those skeletal muscles, like you're going to see a large efflux of potassium outside of the cells, right? Because this is going to be how the cell tries to get itself back down to resting membrane potential, right? So it's going to have that repolarization phase. But you're going to find that after you get succinylcholine, potassium levels are going to go up, right? And so this is why things like hyperkalemia is going to be important to as a contraindication, because if they have hyperkalemia, and who might have hyperkalemia? Yeah, so renal patients primarily are going to be the big ones, right? Especially if they miss their few rounds of dialysis or something. Their Ks are already going to be high. If I give them succinylcholine, the K is going to go up even further, and that can lead to what? Arrhythmias, right? So again, hyperkalemia can be potentially deadly. You do not want to exacerbate that. If their K is already like 5 or 6, you don't want to drive that up any higher. Right. So again, looking at adverse effects, obviously the fasciculations can be an issue here. Usually not so bothersome for the most part. However, this can lead to some transient increases in intracranial pressure, right? So it could maybe one thing you want to avoid with that. I mentioned the hyperkalemia due to that, those potassium channels opening up on the skeletal muscle cells, trying to efflux that. Because again, we're trying to keep them in that refractory period, so it'll efflux that potassium and not really be at a good phase to try to get that back in. So you'll definitely see rises in potassium with succinylcholine being given. Succinylcholine being, acetylcholine receptor or acetylcholine molecules, kind of stuck together. They can certainly cause some bradycardia based on the muscarinic receptors in the heart. So you do want to watch out for bradycardia. We see this a lot more in pediatric patients. They tend to be much more likely to vagal down during laryngoscopy. So you want to be careful with that bradycardia there for succinylcholine. And then we mentioned malignant hyperthermia. When you think malignant hyperthermia, you want to think succinylcholine and you think inhaled anesthetics. So they're going to be the two big classes of drugs that can cause that. So again, you're thinking like, man, this has a lot of side effects. There's a lot of issues with this. You're going to find with the non-depolarizing drugs, they have none of these other problems. Okay, so this is why a lot of people end up not even using sucks. They will often colloquially say sucks. Right, and those use something else. So again, but it's still frequently used. You still want to be at least familiar with it. So, as I mentioned, the fasciculations are associated with increased intracranial pressure, increased intraocular pressure, so you want to be careful with that. Again, we don't really know the full effect for why this is occurring besides the actions of the drug. However, it's one of those things where you can pre-treat with lidocaine. And sometimes what they'll actually give is called a defasciculating dose of a non-depolarizing drug. I'm not really going to quiz you on this. This is kind of a more esoteric thing. We don't do this too frequently. This is actually where you give a small dose of another paralytic beforehand and to try to prevent the fasciculations. But at that point, I'd just rather give the other paralytic the full dose. So don't worry too much about that. Just know that it can increase ICP, can increase intraocular pressure as well. Okay, so I mentioned the hyperkalemia. Normally, after giving a dose of succinylcholine, you can see the potassium rise 0.5 to 1 mil equivalent per liter. And what's a normal potassium? 3.5. Yeah, usually 3.5 to 5. Depends on which lab you're looking at. It might be a little bit different. Usually 3.5 to 5, considered pretty normal. So again, if your potassium is 3.5 and it bumps up to 4, is that a problem? Not at all. If your potassium is already 5.5, is that a problem? Very potentially, right? Especially if any kind of cardiac history. So you got to be careful with that. You may also see, especially if patients who have rhabdomyolysis, so you can see after like a crush injury or something, especially if they have that receptor upregulation, which is where I was talking about the burns, the spinal cord injury, neuromuscular disease. Those tend to upregulate acetylcholine receptors as well. You'll see an exaggerated increase in potassium rises, and that can be potentially life-threatening. So you want to be careful with that. So. Again, just know the timing, just look at that and kind of make your assessment like, okay, you had a burn 3 days ago. And again, it's not like, I burn myself on the stove. It's like, massive burn injuries where you want to be careful with that. Okay, we'll talk about hyperkalemia a little bit later, how we can treat that. But basically, when you see that receptor upregulation, burns, especially 5 days or so after injury, but 2 to 3 days, you can already start to see that. Any kind of denervation injuries, crush injuries. Again, talking about renal failure, you got to be really careful with this one, mainly due to the fact that they're going to have increased potassium, most likely anyway. And again, when you're having someone who's coming in who needs to be intubated rapidly, do you have time to get labs? Not routinely. You could probably do like an ISTAT or something. Have you guys heard the term ISTAT before? Basically, it's a point-of-care test. You can actually do like an blood gas right at the bedside. You can get potassium off of that, but again, you may not even have that available in time. So again, if you don't know what the potassium is, I'd probably just avoid succinylcholine altogether, right? So that history of renal failure, history of dialysis, probably just not use it. So I mentioned that malignant hyperthermia, very rare. It's actually due to a genetic condition in which the ryanodine receptor, you guys remember that ryanodine receptor, where you find that in skeletal muscle? That's what's going to be located on that sarcoplasmic reticulum within the cell that allows for that big calcium storage to be released. Some patients can have mutations in that where when it gets interacted with like succinylcholine or when it is inhaled anesthetics, it's going to release way too much calcium. And if you release way too much calcium from that store, what's going to happen in the muscle? It's going to contract, right? You need calcium in order to contract the muscle, the actin, the myosin, and all that. You have very severe contractions. You're going to have a lot of heat production as your muscles use up all its oxygen and switch over to anaerobic metabolism. You get very acidotic. You get a lot of heat. They can have rhabdomyolysis that can occur, which is a muscle breakdown. So you can be very careful with that. So any history of like a bad history with anesthetics, probably just go ahead and avoid succinylcholine as well. We'll talk about this in the surgery section additionally, but dantrolene is going to be one of the main drugs we use for this. And every hospital, every ER and every OR should have access to a malignant hyperthermia cart typically, where they'll have a lot of dantrolene in there, along with other things we can like do to like cool the patient down. So usually have like a little fridge attached to it with like some cooled saline in there. We'll also have a lot of bicarb, and sodium bicarb would do what for us? Yeah, it would alkalize the patient. It'll get the pH back up if they're turning acidotic, right? So again, you'll find that in most hospitals. But anyway, so it's going to be good to help try to relax the muscle. It'll help to get the temperature back down and hopefully get their acid-base status kind of fixed there. Bless you. Okay, so again, looking at absolute contraindications, anything where they're having or when you're having this malignant hyperthermia, you're having that loss of intracellular calcium control. So as you can see, that muscular rigidity that can occur there, which can certainly interfere with your intubation. You see hypoxia, hypotension, hyperkalemia, all these bad things. So again, be very careful. Make sure you at least ask the history if they have any issues with anesthetics. Okay, so now as far as reversal agents, so again, usually they're anesthetics or your paralytics. Like you want to be able to reverse this if possible, right? Because again, you want to keep the patient paralyzed longer than you need to. In this case, we actually don't have any good reversal agents for succinylcholine. But the nice thing is it's very short acting, so as long as you can ventilate the patient, you can allow for the drug to wear off, and you're generally good to go, right? However, if you have something like bradycardia occurring there, you can give atropine to help reverse that. So that would be one thing you could do to kind of block at least that acetylcholine effect on those muscarinic receptors. However, no other good reversal agent to speed up the process of reversing this. There actually is a drug nowadays, but I'm not going to go into it since it's pretty new and we don't use it too frequently. So looking for special considerations, if you already have a bradycardic patient and you are worried about succinylcholine causing further bradycardia, what could we give for that? Atropine, right? So we can give atropine as an antimuscarinic on the heart there. We mentioned if they have any history of possible increased ICP, give lidocaine to try to block that because we know succinylcholine will raise that as well. And again, this can be lethal in the wrong hand. So there's not a ton of drugs where I'm like, this can kill somebody, but this is one of those ones that you want to be very careful because just outright, yes, it will kill somebody because it will cause them to stop breathing, but it can also kill them from lots of other things as well. So be very careful. Make sure you are ready to prior to giving them the drug, they're going to be paralyzed. You need to be able to ventilate for them. And so usually as part of that kind of the process to get ready for intubation, you're going to be giving them lots of oxygen, try to get them good oxygen stores ready to go. Because when you get them paralyzed, they're going to stop breathing on you. You need to be able to intubate. But again, no effect on consciousness. You have to give them a sedative beforehand to make sure they're not going to be aware of the whole process going on. Okay. So that's a scary depolarizing neuromuscular blocker. The other ones we use most commonly for RSI are going to be Vecuronium and Norcuron. These are going to be non-depolarizing neuromuscular blockers. And so again, no sedation, no analgesia, anything like that. But these are going to be much less dangerous from a side effect standpoint. Really, they still can be very deadly because they cause you to stop breathing, obviously. However, you don't really run into these potassium issues. You don't run into these contraindications. These are pretty much safe for anyone to get from an intubation standpoint. And so the way these are going to be working is they actually will block the acetylcholine receptor, the nicotinic receptor right there on the neuromuscular end plate to prevent any other acetylcholine from actually interacting with it. Okay, so they're basically just pure antagonists at that nicotinic receptor. So again, the only thing you're going to find, these typically are going to be sticking around for a little bit longer than you see with your succinylcholine. So some people like Sux because it's very short acting, 5-10 minutes is going to start to wear off. These are going to stick around for a little bit longer. So like I had one doc, he's actually the chief of the ER, so he was the one that kind of made all the big decisions around there, and he wanted the standard to be succinylcholine and Etomidate for their RSI kits. And because again, every hospital usually have like kits you have available for that sort of thing. And he's like, I want to do succinylcholine. I was like, why do you want to do that? We have Rocuronium, we can have Vecuronium, we can use this much safer from a side effect standpoint. He's like, well, it's shorter acting. If I need to do a neuro exam, I can do that. It's going to wear off faster. So again, everyone has their kind of priorities on that sort of thing. Usually older school guys will always go Sux. Most newer providers, they don't want to deal with that, all the side effects and contraindications. They'll go with Rocuronium or Vecuronium. Again, you're going to find that patients with liver failure tend to have a longer time to recover because they're not going to be metabolizing as quickly. So that's one thing to note with that. So you may need less sedation overall to maintain paralysis. For some patients, you do have to keep them paralyzed for a long period of time, and that's usually going to be due to issues where either you don't want them moving at all, maybe due to intracranial pressure issues, or if you need them to be synchronous with the ventilator, if they're kind of bucking the vent quite a bit, that you may need long-term paralyzation for that. So just know you may need reduced doses if you have a hepatic impairment patient. Rocuronium is probably the most common one we use with RSI outside of succinylcholine. So again, this is probably the go-to for RSI as far from a non-depolarizing neuromuscular blocker. So again, would you see any fasciculations with this? Nope, it's non-depolarizing. It's not going to activate that receptor. It's only going to block it. You're also going to find less vagolytic properties. You're going to find you're going to be less likely to cause bradycardia with this drug. You're going to be less likely to run into any kind of issues that you saw with succinylcholine. Let's see. So again, competitively, they're going to be blocking that acetylcholine receptor. This one as well is going to have some liver metabolism, so you want to be careful with that. And the reversal agent for these non-depolarizing neuromuscular blockers are actually going to be acetylcholine esterase inhibitors. So why do you think that works? The nicotinic receptor antagonist kind of sitting there on the receptor. What's the one way I can kick it off the receptor? Increase acetylcholine levels, right? So if I give them an acetylcholine esterase inhibitor, that will actually kick it off the receptor and kind of reestablish that normal transmission. So we don't do this very frequently in the ER, but certainly in the surgery world, if you need to recover a patient more quickly, if you had them paralyzed for the duration of a procedure, they're coming out, you could reverse them by giving them the Neostigmine, which will block acetylcholine esterase. It will allow acetylcholine levels to rise, and it should kick that paralytic off the receptor, and they should start to have regain function of their neuromuscular control. That kind of makes sense. Anyway, this one does not work on succinylcholine because remember, succinylcholine activates a receptor and then keeps it in a kind of refractory period. So different mechanism than what we see with these non-depolarizing drugs. Okay, this one again, very fast onset, but again, the duration is a little bit longer, so may not be good if you need to do good neuro exams on your patients because again, they will be paralyzed for a longer period of time there. Let's see. Okay, so just remember if they're having seizure activity, this even though it looks like you have a patient with tonic-clonic seizures, if you're giving them a paralytic, those tonic-clonic movements will go away. However, it doesn't mean they're not seizing. So that's where you need things like bedside EEGs. They can be useful to kind of monitor for that. So just be aware that it's not going to fix your issue with that. Physically, they may look better, but they're not going to fix the underlying problem there. A couple other neuromuscular blockers. These might be used for more long-term paralysis, especially up in like the ICUs. So you have things like Vecuronium. This one's actually is a vagolytic. Anyone know what vagolytic means? So we talked about sympatholytics before, right? Like clonidine. What does that do? Should decrease the outflow of the sympathetic nervous system, right? So being a vagolytic, it should decrease the outflow of the parasympathetic nervous system, right? So again, this is going to decrease activity. The main thing you're going to see is going to be tachycardia associated with this. So basically, it's kind of blocking the ability for those vagal nerves to stimulate the heart. So tachycardia is not going to be good for cardiovascular patients. So anyone in the history of MI recently or anything like that, it would not be a good one for them. What we use a lot more commonly is going to be this drug called cis-atracurium, or Nimbex. Most people just call it Nimbex. And again, this is another non-depolarizing neuromuscular blocker. This is going to be good for kind of more long-term paralysis for those patients. You may see that being used. And it's also nice because it doesn't undergo any kind of hepatic or renal metabolism or elimination. So it's good if you have a patient with organ dysfunction. This is a really good drug to use for them. So you may see these, especially if you're up like in the surgical ICU or the ICU, you may see these drugs being used occasionally. So, as I mentioned, reasons why you would want to keep a patient paralyzed for a long period of time, because usually for an intubation, you paralyze them once they're intubated, you don't need to continue the paralysis any further, right? Most patients. There could be some needs for long-term paralysis that I've kind of mentioned. So synchronization with the ventilator being one of the more common ones. If you need to reduce intracranial pressure, it can be one. Actually, this is another good one. If you had to have a patient undergo therapeutic hypothermia, which in what cases might you need to do that? Yeah, post-MI, so we cool a lot of our MI patients. There's probably going to be more uses for that as we go forward, but MI is probably one of the big ones. But it actually will prevent shivering, because again, what does shivering do to your body temperature? It's trying to heat you back up, right? So again, if you can paralyze that and prevent that, that can actually help to keep your temperature down where it should be to try to help save that tissue there. Or if you had someone who's moving around too much for a therapeutic procedure, like if you need them to be completely still for an MRI or something like that, that can be useful for that as well. However, complications, right? So if they're paralyzed, they're obviously not moving very much. What can happen with all that venous blood? It's going to be stagnant in a lot of cases. This is where you need things like making sure you have DVT prophylaxis, right? What can we use for that? Yeah, enoxaparin would be a good one. What else? For sequential compression devices, you have compression hose, things like that. So again, think about things you can use, again, non-pharm and pharmacologic therapy there. You can have ventilator-acquired pneumonia. Certainly can be a risk. And anytime you have someone who's intubated, that is going to be a risk for those patients longer there. Corneal abrasions, why do you think that happens? They're not blinking, yeah. Again, you lose that blinking reflex. So again, so we might have things like erythromycin ointment we're going to be applying to them to make sure, or artificial tears or something to try to make sure we're keeping the eyes nice and moist to prevent any of those abrasions. And actually, with long-term paralysis, you can find these patients, as soon as you take off the paralytic, they can actually stay paralyzed for a long period of time because they basically have this neuropathy that occurs that can take a while for it to actually kind of reverse itself. So, has anyone ever heard of a train of 4? So this is actually how we can monitor to see how paralyzed the patient is. So for instance, in order to get a patient nice and paralyzed, we don't necessarily need to block every single nicotinic receptor on that neuromuscular junction. We only need to block just enough of them, right, to prevent really kind of a good action potential from happening here. So what we can do is monitor to see what our level of paralysis is for these patients, and we'll have this we call a train of 4 monitor. And basically, this is a peripheral nerve stimulator. There's different varieties. This one has these electrodes here, and basically you place it along the ulnar nerve. It's the most common site, and if you ever get to play with one of these, it's kind of fun. But basically, you're going to see it will send 4 electrical signals through. And what might you imagine if you stimulated that ulnar nerve? As you'd imagine, you can see contraction in the hand. So again, if I gave it to one of you guys, how many contractions would I expect to see? 4, right? A paralyzed patient, depending on how many of those receptors are being blocked, you see fewer than that, right? So again, if you have 0 to 75% of receptors, you're going to have maybe 4 twitches, right? You start to get more than that, 75% or so, maybe 3 twitches. 2 twitches, maybe around 80%. Again, these numbers are not important to know. Just know that we are testing for how many twitches there are, and based on that, you'll see just how paralyzed they are. If you see 0 twitches, that means they're very, very paralyzed. Do you need them to always be at 0 twitches? No, sometimes you just need them paralyzed just enough to get them like synchronized with the vent or whatever. Typically, you do not want to see 0 twitches. Usually 1 to 2 is going to be fine for most patients. They still require it. And so that's important to make sure we're monitoring for that, make sure they don't get too much drug or too little drug from that standpoint, right? Just one of those cool kind of monitoring things we can do to actually monitor how well our drug is working. Okay, so what would you do if an intubation didn't go as planned? So say you're trying to intubate, but say maybe there's an injury or the patient has really bad anatomy. We see that with some of our kids who have a really kind of just funky anatomy going on with that, very difficult to intubate. These drugs don't last forever. Like we pick these drugs because the duration is long or short. Because they're short acting, right? So we want to make sure that we're kind of monitoring for that. So again, succinylcholine, maybe 4 to 10 minutes before it starts to wear off. Etomidate, 6 to 10 minutes before it starts to wear off. You want to make sure that if your patient is not intubated yet, you need to redose that around the 5 to 10 minute mark. Okay, and so that's one of the things, at least that I'll do from my standpoint, being in the ER room, saying like, okay, well, it's been 5 to 10 minutes. Do you want to do a second dose? Or the nurse might say, hey, the patient's starting to move. Do we want to give a second dose? And then because again, the provider may be really kind of focused on getting the intubation, they may not be kind of cognizant of what else is going on. So again, that's why more heads are usually better in those situations. Again, no one should be paralyzed without sedation. That's just mean. And you're going to find that patients are much harder to intubate if they're not paralyzed, because again, they will have those contractions of the muscles in the airway. They just need to kind of loosen everything up when you're doing that. So again, 5 to 10 minutes or so, think about a second dose. All right. So as kind of a summary for RSI, there's lots of different agents that are going to be available here. No one drug is going to be perfect for every single patient. So you need to look at contraindications, you need to look at side effects, you need to think about who's going to be best. So again, I'll ask questions like that on the test where you say, hey, patient's coming in secondary to traumatic brain injury, what's going to be good for pretreatment? You might say lidocaine, atropine, naloxone, something else, right? And what would you use for someone with the TBI? Because you're worried about increased intracranial pressure, so you want to give lidocaine, right? So lidocaine would be a good drug for that. So those are kind of things I might ask on the test. What might be a good drug selection for a patient? Because again, when you're doing an RSI, you got to think quick, right? You got to think about what's the contraindications, what's my patient history. I think a dialysis patient, what am I not going to want to give them? Probably not succinylcholine, right? Because again, that could cause hyperkalemia. Patient may already be hyperkalemic, see an arrhythmia. Don't want to do that. So little things to think about. As I mentioned, a lot of newer providers, they just get used to using Vecuronium because it lacks a lot of those side effects and contraindications, but you will still see enough sucks being used that you need to at least be familiar with it. Any questions on RSI or intubation in general from a drug standpoint? Okay. I think I'm going to go ahead and cut it short today. You guys okay with that? I imagine so. Any questions before I let you guys go? All right, well, I'll see you next time. We'll finish up our ER stuff, and that should be the end of material. I think Friday we meet, and that'll be the end of the material for the test. We'll do a review session after you guys come back from spring break, and I think the test will be that following Monday. Is that correct? Sound right? Okay. All right, I'll see you guys next time.